Okay. Close on my screen, yes?
Yep.
Okay. So I guess came across this case the other day. This is kind of an older case from our file, but I thought it was a good one. So this is obviously a chest radiograph. We can see that this patient had a stent placed in the descending aorta. They also had a little occluder in the left, I think, subclavian that was placed at the same time. And if we look at the contour of the heart, right, you can see that there's quite a bit of soft tissue outside the stent. And we can take a look at his prior imaging. Sorry, zoom out. Right, where we saw this was done pretty, about 4 years before that radiograph I was just showing you. This is right after the stent was placed, so there's been quite a bit of soft tissue out there. But on the more recent radiograph, we can see that there's this little linear lucency that's in that soft tissue. And then if we look closer, there's another little lucency here. And so all of that is suspicious that there's air somewhere in that soft tissue in the mediastinum. So patient went on to get a CT. And we can see, as I scroll through this, that there is quite a bit of air in the excluded portion of this aneurysm. Going all the way down, there's also some calcifications, those were chronic, but quite a lot of air in that excluded aneurysm sac. Luckily, none of it seems to be within the stented portion, but this was highly concerning for an infection of this excluded aneurysm sac. And so I think the thought with this was that if we come down, we can see the esophagus is very close to the aorta here. The concern was that there had developed over time an esophageal aortic fistula that was leading to this infection here. We did, or somebody did do a fluoroscopic esophagram. I'm just going to show one image, right? We can see that there's good contrast opacification of the esophagus, no clear contrast extraluminally. So we couldn't prove that there was a communication between these two on that fluoroscopic esophagram, but I think that was still the concern as to where this air in the excluded sac came from. And so this patient is now currently on lifelong antibiotics. I think they were high risk to go back and get, this surgically resected. So currently doing okay, but just on lifelong antibiotics for this.
So this wouldn't be an indication for an esophageal stent then?
I think that's a great thought. I think they didn't go down that because they couldn't clearly prove that where exactly the communication was, if any. I mean, obviously it probably would be down here where it's touching it, but that's a good thought. No, they hadn't. I didn't see in any of the notes that they were considering that. But yeah, this case was originally from, I don't know, a year or two ago, and I was just checking as I was pulling this up, and the patient's still doing okay on antibiotics. So interesting. Okay. And then I had one other case. Maybe it's going to open both of them. Yes. Great. Okay. So this was a case that I was reading just the other day. And it was a follow-up cancer staging in this patient who, as we're scrolling through, you can see had a prior pneumonectomy, so had the left lung removed. But focusing on the right lung here, you can see as I'm scrolling through, there are many of these small ground glass nodules really throughout the lung. Some of them have this sort of classic kind of Cheerio-like appearance with central clearing. And you can just see, the more I scroll through, the more you can see, right? They're pretty much everywhere throughout the lung. And so these have a good look for minute meningothelial or minute pulmonary meningothelial-like nodules. And we can see actually going back in this patient, this is a CT from 8 years prior. This is before they had the pneumonectomy. They had the pneumonectomy for this large malignancy down here. But we can see that all of those nodules are throughout that left lung as well. Um, but the ones in the right lung look very similar and really haven't changed over the course of 8 years. Here's that little Cheerio one again. And we actually do have the path report from the pneumonectomy, which confirms this, that the patient did have meningotheliomatosis. So these are all tiny meningothelial-like nodules. I thought it was just nice that we have an actual pathologic correlate since this patient did go to pneumonectomy.
Is it
Nice.
is it a lady, a woman?
Yes.
Yeah. Okay.
Mm-hmm. Yeah, and I was looking
Very
to
nice.
see, I couldn't find any correlation between the meningothelial nodules and malignancy, so I think this was just an incidental that they also happened to have a pulmonary malignancy on top of this. So yeah, those are my cases.
Very nice.
Thank you all.
Nice, thanks. Who wants to go next?
I've got a couple.
All right. All right, you should see the prompt.
So this 40-some-year-old man came to the emergency room with, I think, some sensations from his neck, as if he was choking or something. It's a little vague. And he had this chest radiograph. We have no previous record on him. He was visiting Seattle from California, so he doesn't have any medical records in Washington State. So this alarmed the resident appropriately, and there was a lateral view that shows one of these big masses posteriorly here, and you can see there are anterior masses too. There are really masses everywhere. So this prompted a CT scan, which is also abnormal. So we have these big masses, many of which are paraspinal, others of which are adjacent to expanded ribs with cortical erosions of sort of porous looking bones everywhere. All the bones are abnormal here, expanded marrow spaces and so forth. So this is slam dunk for extramedullary hematopoiesis. The presence of fat in some of these lesions was thought to be atypical, but actually we've seen that before. And I've seen a case in which the person had dramatic paraspinal masses like this, and when the person was given adequate hemoglobin replacement, got enough transfusions on board, the extramedullary hematopoiesis, the dense component, regressed, and we were left with a lot more fat. So these lesions can be replaced entirely with fat if the marrow elements are not being hyperstimulated. So this is almost certainly beta thalassemia. I've seen extramedullary hematopoiesis in sickle cell anemia, but usually not to this extent. So this fantastic extent really goes with beta thal. The man went back he was given a appointment in hematology, and of course he went back to California, so he's going to pursue the work up there. But we really have no follow-up, and he gave no history of having had a lifetime of thalassemia, which he probably has at his 43. Now he has had splenectomy, so somebody might have been attuned to this, and he has a dense liver, as if he's received a lot of transfusions or has a high degree of iron turnover here. So it looks as if, I mean, if you told me, I mean, these might be signs of treatment here, but the guy did not give us any history of that. So it's kind of frustrating, because we don't have, you'd think that he would have a solid diagnosis of beta thal by the time he got to his 40s. But a rather dramatic case of extramedullary hematopoiesis. And you can see that all these soft tissue masses are really pretty much adherent to bone, and you could easily hypothesize that it's the cortical defects that allow the marrow to leak out and set up housekeeping outside the bone here, because the extramedullary hematopoiesis tends to be osteotropic here. Okay, so that was abnormal, and a satisfying diagnosis. When you recognize extramedullary hematopoiesis, it just leaps out at you. No hesitation with that look. It was thought by the overnight resident to be lymphoma or metastatic cancer. Any comments?
Nice case.
Dramatic.
Yeah,
We
very dramatic.
don't see very much of that here. Okay. Okay, let me proceed to another case here. So this woman also has an abnormal chest radiograph. You see a lot of those, and there are all these smooth, well-defined masses everywhere, concentrated in a nice hematogenous distribution, concentrated mid-lungs and bases, and very clean and discrete looking lesions here on CT as well. There's one that looks a little more aggressive. It's larger here and may have some necrosis or cavitation in it. We checked an abdominal CT scan, and this woman had had hysterectomy. There is a needle biopsy confirmation, which I've not reviewed, but I was told about, that shows that this is benign metastasizing myomatosis. So many lesions. I don't think I showed a case a few years ago, but it wasn't as dramatic as this one in terms of the number of lesions. So this usually follows some surgical manipulation of the uterus, which allows the leiomyoma cells to get into the circulation, and then they land in the lung like this instead of housekeeping. So it's metastatic only. It's not because it's aggressive and invasive, but because a surgeon created the pathway to the bloodstream and therefore to metastasis. Now, these lesions, there is a possibility that these lesions can degenerate into leiomyosarcomas. And so when you see this strange looking lesion here, that would be a possibility. I don't know whether that has been pursued. I'll try to get more history for next week. So
I've never seen that many.
What?
I mean, that's pretty crazy. I've never seen that many. I mean, I have ones that are like a couple nodules, but nothing like that.
Yeah. Okay. So lots of blobs. I think you showed one a few weeks ago, right?
A few months ago, but it wasn't like this. I mean, I had a couple nodules. I mean,
Okay. Yeah. Well, we grow them big up here. It's a cool, long growing season that we have.
I think this is an example where the term benign is a misnomer too. If this patient's eventually going to die of these, I mean, if it replaces all of her lungs.
Yeah. Yeah. It's benign in the sense of it's not being invasive. That's,
Yeah.
but you're right. Okay. Those are the cases. Thank you.
Nice. Seth, you got
I
some?
can go. I can go if you want.
Sure.
Let me just close my pack. Sorry, I just want to make sure there's nothing on behind me. Oh my lord, this thing is such a pain in the ass to close. Sorry.
We didn't.
You can hear all the things beeping because it will not let me exit. Oh my god. Okay. After. Oh, and it's on the wrong screen. Okay. There we go.
Good.
This is an interesting case because, well, more for a discussion. You can see here that this heart is not normal, but it's more than just the mild wall motion abnormality. If people look in the septum and actually all over, you actually see there's a ton of chemical shift artifact in the myocardium, in the mid-ventricular, sorry, the mesocardial portion, kind of the mid cavity. And you can see it all throughout. It's all throughout the left ventricle. This is confirmed on, sorry, I have a lot of sequences here. So here's our, oh, come on. Here's our T1 here, and you can see there's all this fat here in the left ventricle. And then if I search around long enough, I'm sure I can find my T1 dark blood somewhere. That's, I don't know where they are. So somewhere in here is a fat sat, which shows that all this stuff, this is a T2, but nonetheless, you can see it's a fat sat, and you can see all this stuff saturates out. So there's an abundant amount of fat in the myocardium. Here is the post-contrast imaging. Again, if I can find it, which really shows quite pronounced mid-myocardial, maybe in some areas you would call it subepicardial, linear delayed enhancement. And, given all the fat in the myocardium, so this is probably, so it's an interesting case. He has a family member who has limb-girdle muscular dystrophy. He is completely asymptomatic. He came to kind of recognition because of an EKG abnormality. So it's probably limb-girdle, some form of limb-girdle muscular dystrophy. But there's another entity that I actually didn't know much about until kind of recently. We always talk about arrhythmogenic right ventricular dysplasia or cardiomyopathy, but there's also a variant that is just isolated to the left ventricle. And it's associated with some of the genes are the same, but some of the genetics are different. And it looks like this, where you have linear areas of mid-myocardial delayed enhancement, fat on MRI. So it basically looks like ARVC, but it can involve both ventricles, but it can involve also just the left ventricle. So it's an interesting case, and again, it's probably fat from the muscular dystrophy, even though he's 60 or 55 and has no history of muscular dystrophy. But I just had not heard much about this arrhythmogenic left ventricular dysplasia, and in the papers that they talk about it, this is the characteristic delayed enhancement pattern, where it's mid-myocardial and intense linear enhancement. Had you guys heard of that before?
No.
I have cases of RV involvement that involve the left ventricle, but there are now a lot of reported cases of just left ventricular involvement. So anyways, I thought that entity was interesting to know about.
So Seth, are these findings reported in that limb-girdle muscular dystrophy?
I'm sorry?
So are these findings of this kind of dysplasia reported in limb-girdle?
Yes, this would be the most pronounced case I saw in the literature compared to what we've seen, but and yes, you can. I have cases of DMD that have more characteristic and patterns like this, but limb-girdle can involve the heart.
Got it.
And it can have, just like this, this is really just a non-ischemic pattern. I didn't see any case reports showing the macroscopic fat, although there is fatty deposit, there is fatty replacement of musculature in limb-girdle muscular dystrophy. So the answer is I'm not sure. What they're going to do is genetic testing, because there's genes that you saw that some of the genes with arrhythmogenic left ventricular cardiomyopathy, but there's other genes obviously associated with limb-girdle. So they're going to do extensive genetic testing and try to figure out which one it is. But yes, the answer is it could be either.
Very interesting.
This is kind of interesting. I mean, it's one of these, there's a ball in the lung and it's unchanged over many years, and it's, what kind of bug is it? This patient had this CT, was unchanged they actually knew the diagnosis. I think someone had biopsied it in the past. There's nothing in the liver, which is the one thing that may kind of clue you into the diagnosis. And it's just a kind of a cyst, a necrotic cyst-like thing with a couple of bubbles of air. I'm guessing the bubbles of air had been there for many, many, many studies. So I'm guessing it formed a little fistula with one of the airways. But anyways, this was high dated. I didn't have many interesting cases today, but here's a treat, and it's treated. So when they took it out, they saw the kind of the classic lamellar or whatever foldings of the cyst, but they didn't find any organisms in it because he had been on treatment for a long time. So that's just a high dated cyst. I didn't have much interesting this week. This is only interesting because it just shows, I think, and I've showed cases of this in the past where it's actually dramatically positive of Fabry's disease or Fabry's disease. I don't know what you want to call it. Still not sure if it's Fabry's or Fabry's. But this LV looks kind of normal. There is some hypertrophy involving some of the basilar segments here, but this is a young guy who has Fabry's disease. He does have some hypertrophy of the segments, but his delayed enhancement is completely normal. Nothing at all. But what was interesting, and you have to take my word for it. We did tissue mapping, which is always very helpful, and his tissue mapping was quite low. It was about 840 or 850. So, this is a 1.5 T scanner, and on most 1.5 systems, it depends, but we all know that normal is somewhere around 1,000-ish. I mean, it can vary a little bit. I know in the Siemens that it's around 1,000. And he was, again, like 850, 860, and that was at every single level. So I did it, both at the base, the mid cavity, and the apical levels. And he was in the mid eights, anywhere from like 850 to 890, 880 at every level. So we know that, this is a lysosomal storage issue, and that they get fatty material, fatty infiltration in the musculature. So, because it deposits, it just depositions. So they get the sphingolipids, I think. I don't know, you guys know better than me, that can deposit. So here, even though the CT morphologically on delayed enhancement looks completely normal, the tissue mapping helped, I don't know if they're going to change, but helped suggest that there probably is, and there's a little bit of hypertrophy which goes along with it, but probably is some mild deposition in the myocardium, although it's not overt. Anyways, I didn't have much this week. That's what I got.
No, those are great.
All right, Travis.
Sorry, I couldn't unmute. All right. Howard, do you want to go?
Okay. Okay, I'll start with this one. Now, I'm going to withhold some information about this patient. I'll tell you that all the tubes and the surgery that you see here was the unfortunate result of a patient transferred here, as best I can tell, at the initiation of a certain surgical procedure, which I'll mention in a moment. Things didn't go well. There was some kind of arrest situation, and the patient ended up being placed on ECMO and then transferred here for further evaluation, for further management of, in part, ECMO devices. Just with respect to one of the devices, I just want to show you one thing. So the patient has cannulae for ECMO. Here you can see one in the IVC. I just want to clarify that this tube that you see coming in here that goes via a superior pulmonary vein into the left atrium, across the valve into the left ventricular chamber here, with an attenuating object there, which is what you will see if you are lucky and look for it on a radiograph, is intentional. It's a left ventricular vent. So they do know that some patients will develop left ventricular overdistension in the context of ECMO, and they will use a left ventricular vent like this to decompress that left ventricle. And the blood that's taken out via this left ventricular vent is connected with the Y connector to the venous side of the circuit for ECMO. What I want you to look at here on this non-enhanced, contrast-enhanced CT is the appearance of the lungs down here. So no contrast medium, and the lungs are intensely white down here. And Now I will switch over to show you the aerated upper lung zones that look like that. And then go back to the mediastinal window and take a look at the amount of mural wall calcification in relation to the left atrium. And then I'll narrow the window width so that you can get a feel for how hyperattenuating myocardium is here compared to muscle, skeletal muscle, and blood in the heart. So too much calcium. So we have calcium in the lungs up here. And because the lung is atelectatic down here, they look like that. So this is a patient with chronic renal insufficiency from childhood. And this is so-called metastatic pulmonary as well as cardiac left atrial myocardial calcification from that pretty dramatic amount of calcium. It's a pretty scary sight when you see it like that without contrast medium. If you don't have the non-contrast, you wouldn't pick up that that's in there, at least in here, in the same way.
Oh, never been on amiodarone?
No, no, no,
Wow.
no, no. This appearance up here is pretty typical. These geographic ground glass attenuating, diffuse,
Agreed.
lobular, centrilobular opacities of so-called metastatic pulmonary calcification throughout the lungs.
Impressive. Person must clank when he breathes.
This is an unfortunate patient. Their patient developed secondary hyperparathyroidism, and the surgical procedure was the initiation of a surgery directed at the parathyroids when things went wrong. Not clear what happened. Okay, this is a case that has a lot of lessons to it, and some of it is perplexing, but an unfortunate outcome. So I have a series of images, first from an outside institution, when the patient was transferred here from an outside institution with a diagnosis. But I do want to show you that initially at the outside institution, a CTPA was done. And I've shown you this before, but as I scroll there, we recognize that we do not have opacification of the aorta and the left-sided structures very much. And then there is a clue here on this image right there, and maybe really subtle, maybe there's a linear lucency right there, but that should tell you what I'm about to show you when you get a CTA where the contrast medium is opacifying the left side properly. There you go. So here is the displaced calcium right there. We have a type 1 dissection. You can see the extent of it, and the true lumen and the false lumen, and so on. So the patient went to surgery here. And I will summarize that by saying they paid attention and replaced the aortic root with a composite device, did a ascending aorta replacement and a hemi-arch. The surgeon that then made a comment about, they wondered about whether this was a retrograde dissection with a flap somewhere. And at the end of the surgery, the surgeon decided to place a stent in. I think the stent was intended to be in the distal aortic arch, proximal descending aorta. After the surgery was done, the patient did not do well at all. And I'm going to show you now the post-op imaging when things did not go well. I'm trying to get the right one. So now remember that we're going to see a stent, but instead of seeing the stent in the distal descending aorta or proximal descending, we do not, except down here, we see the top portion of a stent. Now, keep your eye on this stent, and I will tell you as I scroll through that a clinical diagnosis of a very substantial malperfusion involving abdominal organs in the abdomen was provisionally diagnosed. So keep an eye on that stent and see what it does as I scroll down to here, and I'll go back up again. Anyone see anything interesting?
Yeah, it looks like it's
went into the false lumen.
Yep.
Yep. You can see it makes a turn right there. And now below that, this is the false lumen. Therefore, what comes off anteriorly and is being substantially compressed is the true lumen, from which visceral vessels are arising. But now that false lumen has most of the blood flow. The true lumen is compressed, and the amount of perfusion through these visceral vessels, and there turns out to be a replaced right hepatic artery, is very substantially diminished with substantial ischemia involving the bowel and other organs, even the liver, because of a replaced right hepatic artery. So I've not seen this complication before, but there you go.
So Howard, had the stent slipped? Did it slip distally? Was it initially placed near the back of the arch?
Well, I think the intent was to put it somewhere, but I don't know exactly why it ended up being here, David.
Okay.
Their wire must have been in the false lumen and then ended up in the true lumen in the arch. Because
Well,
I think I showed
the stent
a
was
long
placed.
time ago one stent that was in the false lumen.
This is different though, because the stent was placed under direct vision at the time of the operation.
So do you think it crossed from true lumen to false lumen then, or do you think that
Yes, I think it
yeah.
crossed right here.
never in true lumen?
It crossed.
It's in true lumen at the beginning, at the top, right?
Pardon?
It starts out in true lumen at the
Yes.
at the top, and then switches, right?
Yes.
Okay.
So was there a small flap? Was there a small intimal injury? Is it entirely iatrogenic, where the placement of the stent under direct vision, as it were, just went through
Well,
and went right into the false lumen?
the septum here is not composed of muscular tissue. It's very thin. It's intima and a little bit of media.
Right.
So if you blow up a stent in that, you could easily disrupt that fragile membrane that's separating true and false lumen. So, just placing a stent puts that at risk. You can't really get this to fill out a lumen and have some, adequate counter resistance to it. You just don't have the strength in the wall. I don't think that it's hard to tell what was intended with that, because
Right.
there's not enough tissue strength to hold a stent.
Well, false lumen definitely not intended, since that's resulting in the mesenteric ischemia.
Yeah.
Gosh.
Yeah. So this was very perplexing as to how all this eventuated. Yeah. Yeah, very unfortunate. This is just kind of the case where if you start off looking at a post-op CT like this, where you have a history of a surgical procedure done, and it's not entirely clear what was done, except that you have a post-op situation where you see a sternotomy and you look at this and it doesn't look like ordinary aortic surgery of any kind. And then I will show you here that you see this. So take a look at this aorta here. You see, I'll make this bigger. A little contrast there. Then going superiorly, you see this right there. And then it sort of disappears, blends in there. So you've got this to deal with, and you've got this to deal with. And it's really perplexing as to what one is looking at. So now, in the context of ordinary surgical management of aortic dissections and other things, we're used to thinking about things like cannulation sites, and we're thinking about oversewn graft stumps that can simulate a pseudoaneurysm when they're not a pseudoaneurysm. But in a case like this, it's really perplexing as to what this is all about. So this is when going to the medical record, if you have it, is really helpful, because without that, it would be really hard. But I do want to show you some chest radiographs that were done around the time of the prior surgery. So here you can see that, I'll make this big, a prior operation, intubation, pulmonary artery catheter, chest drainage tubes and the like. And there's a left ventricular impeller device. Anyone see anything odd about the left ventricular impeller device? It's
Direct stick into the aorta there.
exactly. So
Wow.
anyway, why is it coming from here? Right, exactly right. So that was taken out.
That's good detective work.
Yeah. So you have to kind of figure what the heck's going on here. So here you'll see that at the time of an operation, the patient began to wean from cardiopulmonary bypass, couldn't come off. They tried to get an assist device via a percutaneous approach, but were unable to do so peripherally, as you can see here. So they took a 10 millimeter graft and they anastomosed it to the ascending aorta and passed the impeller device through that. And then later on, you can see in removing the impeller and the sheath that was taken out, and you can see from the description here that there is a remnant portion of the graft that remained in place that they basically oversewed. So once you have that information, then it makes sense and is not so alarming. Yeah. So, I always tell my residents, you do have to look at the medical record. It's going to save you if you can't figure out what's going on. And if you're lucky enough that you have that information, then it makes sense. So just a rather strange circumstance. Okay, let me show you this one, which is quite nice. So this is a patient who has a lung cancer, which is there, had a right upper lobectomy for that. And if you look at the lungs, you can see the lungs are pretty abnormal. How would one describe that? So knowing that and reading the op report and then the pathology report, I said, oh, this is a great opportunity to get some rad path correlation. So in looking at these lungs in a patient who's a smoker, there are certainly findings consistent with smoking-related disease. But in the periphery of the lungs, particularly here, we have a lot of reticulation, ill-defined opacity. And then, of course, down here, you'd wonder about the entity of basal lung fibrosis down here. And then that broad category of disease, smoking-related interstitial fibrosis with enlarged air spaces. So now, having shown you the appearance of the lungs, I'm going to show you some representative path images. Of course, this comes from the right upper lobe that was removed, taken out. So we have findings consistent with smoking-related interstitial fibrosis. But I really want to show you these images here because these are nice path images. It turns out that the collagen deposition with smoking-related interstitial fibrosis is apparently, to a pathologist who's aware of it, very distinctive. They describe so-called ropey collagen deposition. And if you look at this image like this, you can see that not only is the collagen extensive and often very deep pink staining, but you can see why these cords here may be described as ropes of fibrosis of collagen. So this is a really distinctive pathologic appearance of smoking-related interstitial fibrosis with ropey collagen under a microscope. So that's what we're basically looking at least with respect to the disease that's present in these lungs.
Yeah, you can appreciate why the DLCO is so low in these patients, right? I mean, that collagen deposition in the walls is so pronounced that you literally can't transfer gas. It's
dramatic, isn't it?
Yeah, I mean, and to me, everything here is pretty impressive. Smoking-related fibrosis. Here in it, the issue is that the lungs here aren't insulated, so this is all kind of folded on itself.
Yes, exactly.
So if these were insufflated, they would actually look like puffed up, alveolar emphysematous spaces, but they're just all folded in because it's a lobectomy specimen.
Right.
But it's beautiful. I mean, it's a perfect example. It's gorgeous.
Yeah.
I think the other thing that's really helpful in recognizing smoking-related lung fibrosis is its frequent combination with paraseptal emphysema. So you'll often see them occurring together.
It's so true. It is. They are so conspicuous with the paraseptal emphysema, and yeah, I still don't understand paraseptal emphysema personally. It's an odd thing to me, just understanding the mechanism of it. But yeah, no, it is. It's so pronounced with the paraseptal emphysema.
Yeah, you can see that paraseptal emphysema on this MINIP image I made, and the subpleural cystic spaces, etc.
I mean, and honestly, I would call all this smoking-related fibrosis, even at the bases. I mean, I wouldn't call this.
Yep.
Yeah, I mean, I personally wouldn't call this like whatever the combined one with UIP. I would think this is all smoking-related fibrosis, not UIP associated UIP. I don't know what other people would say with this, but
Agree.
Yeah, we used to talk about the combined emphysema fibrosis syndrome, but I think we know enough about it now just to use the words like SRIF, et cetera, within large hair spaces and so
right,
on.
because a lot of people combine fibrosis and emphysema to them means emphysema with UIP at the bases. I mean, the problem is there's so much confusion with the terms.
Yeah. And then, of course, the astute pathologist seeing all this ropey stuff and also seeing lots of macrophages.
Yeah, beautiful macrophages. Yeah.
Laden macrophages, they just put 1 and 1 and 2 and 3, 4 together for smoking-related disease. Yeah.
That's a very nice case.
Yeah. Is anyone else waiting to show cases? I think I might have.
I've got some.
Okay, I'll save 1 or 2 others for another time. Some
Okay.
of these are from what I showed in previous weeks.
All right, thanks. Those are great. Let's see. I've got 3, and I think they'll get done in the 10 minutes here. This is an interesting radiograph, and this one gets filed under the better lucky than good collection that I have now. And I think if you're looking at the PA view, I think the first thing that jumps out is this, and that was what jumped out to the person. This was from an outside hospital. So certainly really dense, looks like bone, and sure enough, looks like a big osteophyte here. And they had said, question mass, recommended a CT. Does anybody see anything else on the lateral view here, though, that bothers them a little? Because it's super subtle, and I don't think I would have called it prospectively.
Not really.
Dependent fluid level in the soft tissue, is that?
Yeah, right, exactly. I mean, it's just above the aortic arch, and you think it's probably just the arch, but that's really straight there.
Oh, gee.
You don't see it on the PA view. And again, I don't know what to make of it because like nothing here really looks that abnormal. And you'll see on the CT, because this CT was done shortly after that radiograph, that yeah, first of all, there's a big osteophyte here, but there is a huge esophageal mass. Just circumferential esophageal mass that's spans almost 7-8 centimeters, and did turn out to be esophageal cancer. Even this right paratracheal node, I couldn't really see on the radiograph when looking at it again, but it's a good thing the patient got the CT. That just looks like normal lateral interface of the SVC, azygos. Yeah, so. But this patient, did have their esophageal cancer diagnosed as a result of somebody picking up the osteophyte there.
I think one little hint of this thing on the frontal view is that the whiteness is not just the osteophyte, but it extends medially, overlying the vertebral bodies there too. So I think that's the subcarinal mass.
Ooh, it's hard.
Yeah, maybe.
It's hard.
I can buy that. I don't, but again, you don't really. I mean, you just don't even see lymphadenopathy in the subcarinal space in the lateral view.
No,
True.
I don't.
So, I think we should not interpret chest radiographs without an accompanying CT.
Agreed. Yeah. All right. That's that one. Well, the other two are strictly CT. This one's quite the case. So this is a 97-year-old. As you can see, she's intubated at the time, suffered a cardiac arrest, and underwent resuscitation as seen by the presence of these anterior rib fractures, several of them on the left. And she has some component, probably just edema. I think her heart's not doing too great. But look at her right ventricle here. And she has this balloon that is connected to the right ventricle. So pseudoaneurysm from the right ventricle. And looking, I don't see any rib fractures around that area or cartilage fractures in that area. But this is certainly something, laceration of the heart can be associated with resuscitation. Everybody agree, right?
Mm. Yeah.
Wow.
So what are you saying about a balloon?
Well, it just kind of looks like a balloon floating,
Okay.
just
She
coming
wasn't
out of
DNR at
the,
97. That's pretty impressive.
yeah, well, but hold on, there's more. It's actually, this case goes back a few months. So this is February, and notice that there is no pseudoaneurysm there, as we would suspect. I was digging through because I saw that there, and it said likely from resuscitation. And then looking back, she has a pericardial effusion at this time. It's like moderate volume, but there's not really anything anterior. There's some inferior to the heart, but most of it's posterior and here. And so that is the second. This is 3 weeks later, and this is still months ago. And you'll see, let me stop this thing sinking. Well, I can't. And look at that. So this thing has been there since February and was new on this one. And what it turns out, so in the interim between these two studies, they did a pericardiocentesis to drain this pericardial effusion. And presumably just jabbed right into the right ventricle. So, I mean, that would fit with like a subxiphoid window. And the fact that there was not much fluid there in the first place, I bet they just hit the RV.
Yeah.
So to Seth's point, she was do not operate on. I don't know, she got a CT and resuscitation this time, so I don't know what that makes her, but they weren't going to actually operate on that pseudoaneurysm, and it's still there 4 months later. So it actually wasn't from the resuscitation.
Jeez.
So again, like your case of the old Impella, it's oftentimes rewarding to do a little detective work and see what actually happened to the patient. All right, this is just a quick one, just ICU radiograph from the other day. So this patient, you can see they had a right-sided internal jugular port catheter, and that was removed. I don't know why, but a new one was placed, and this was not placed here. But this left internal jugular port catheter doesn't really go down as far as one might hope it does or hope it would. And it goes straight down, and the brachiocephalic vein may be over in here. It may go a little bit lower, but it wasn't working. And so one of my colleagues suggested a CT for the off chance that maybe it's extravascular, because it doesn't take a slam dunk course. And here you can see the CT was done, and it does go into the internal jugular vein. So it clearly starts out in the vein. And instead of going across, though, and it looks like there's probably old calcified fibrin sheath from an old catheter, instead of going across into the brachiocephalic vein, it just goes straight down. And so the question then becomes, is this extravascular in the mediastinum, or is it in a collateral vein? And the person reading this actually thought they favored this to be extravascular. There were some of us that, were on the fence, and I thought this looked like a superior intercostal vein here, and said maybe
it's in the superior intercostal vein.
Yeah. And so, the IR folks went in to do a port check and under fluoro injected it, and sure enough, it is not extravascular, but it's in the superior intercostal vein. So they were going to revise it and put in a new port that actually goes into the subclavian or into the brachiocephalic vein. But yeah, I thought it was just an interesting,
very interesting
collateral catheter case, because that's a subtle vein. But yeah, Seth, I agree. Yeah, you could kind of see it coming off right there, so you assume that's where it is.
Did you see the arthritis in that interventional guy's hand?
Let's see.
It's a young hand.
It doesn't look like there's much. I was actually focused more on the tracheobronchial calcification here. So, alrighty. Well, that's it, and it is almost 4 o'clock East Coast. So we'll see everybody next week.
Thanks, everyone.